your two studies sort of are comparable. So if we come to Antonio, what's your view now on where we should go with lenalidomide maintenance?
Well, certainly at this point we have basically 3 independent studies, all showing a major advantage in remission duration and progression-free survival. One of these is showing a survival advantage. So we have already different independent studies clearly showing an advantage, at least in terms of remission duration. So from this point of view, I think there is enough evidence to use and to translate this data in the clinical practice.
So you can actually access this drug in the frontline setting. So tell me about how that these data have affected your practice.
Well, I think at Dana-Farber, Gareth, we're strong proponents of a maintenance approach. We think that this is a very important way of maintaining remission as the goal, and clearly from a paradigm shift of treatment from induction, consolidation, intensification, maintenance, we see that as a paradigm approach in all patients, depending on what you put in. You know, obviously not for older patients, transplantation isn't appropriate. And I would say, Gareth, that in the US, because we obviously have access to lenalidomide up front, certainly in my practice, maintenance with it is becoming a very popular option. I think we just have to have a couple of words of caution, though. I think in terms of the side effect profile, I agree with you that lenalidomide is generally very well tolerated. I do think you've got to watch for some count suppression, particularly in patients who've had a lot of prior therapy. And I'm particularly struck by data that we've had for some time showing that patients tolerate lenalidomide less well if they've had multiple transplants. And I think, to me, that tells me the important mix here is the lenalidomide. The multiple transplants are not necessarily the way to go.
So I think you made a great point about trumping double transplants, which
exactly.
kind of using a double transplant at this point in time is illogical to me when you can replace the second one with a novel agent.
Right, and I think that's, I agree with you. I think obviously we have to be careful with our randomized trials that are addressing this issue, and we'll have answers from them. I did also want to share one other question, because of course it's been an important one, and that's the question of new primaries. And I think that in the CLGB trial, whilst we have seen a signal, I think it has been less of a concern to us for several reasons. One is that we have obviously the survival advantage. Once you have a drug demonstrating a survival advantage, that becomes very important in contextualizing the risk. The other thing is that Phil did what we call, he did an analysis for progression-free or event-free survival based upon these events. And the bottom line is the difference remains strikingly positive, and in fact, no significant change was seen.
So what about you, Antonio? How do you feel about these second primary issues?
I totally agree. There is certainly a slight increase in risk of second primary cancer.
Well, these competing risk things you did, they're very interesting.
Yeah, but if you put in competition the risk of a diagnosis of a second cancer versus the risk of progression of myeloma or the risk of death by myeloma, the risk of death versus the risk of diagnosis of second cancer is 5-6 times higher. So there is no story from this point of view.
Right, and I think that's a key point as well, because what we also see, and it's clear from the analysis that Michelle has done for the IFM data, is that the genotoxic component is critical.
The DSEP.
Exactly. And the French showed very nicely in the 2005 one that DSEP didn't make a blind bit of difference in terms of outcome.
Just put the toxicity up and gave them
exactly. And now you see this clear association of DSEP with second primaries. And I think that helps contextualize this. We certainly have no evidence to suggest that, for example, bortezomib contributes to it at all. Quite the opposite, actually, from the HOVM trial. So the suggestion would be, to me anyway, with modern combination approaches as part of induction, which, of course, in the US, our favorite is combining a proteasome inhibitor with an immunomodulator. We believe that as an induction strategy minimizes genotoxic stress, and so provides an outstanding platform for then further continuation of treatment.